I'm Rich Kuchman with Strategic Self-Reliance and Defense, and today I'm going to talk a little bit about assessing level of responsiveness. All right, this is a big topic. We can actually go pretty deep into it, but I'm going to just scratch the surface. All right, so level of responsiveness, or LOR, also referred to as LOC, or level of consciousness, really is just a way of determining whether the brain's functioning the way it's supposed to. All right, we're talking about, is somebody alert? Are they awake? Are they oriented? Are they responding appropriately? Are they able to follow commands? Are they thinking clearly? That's really what we're talking about in level of responsiveness. Now, why do we do it? Well, we assess level of responsiveness now we do it for everybody. Every patient gets at least a baseline assessment of their mental status. How awake and alert are they, right? Alert and oriented times, right? Typically 4 is perfect, right? Alert and oriented times 4. But we're not talking about the hospital assessment here. We're talking about a trauma assessment, a quick down and dirty type of level of responsiveness assessment. Traditionally, in the ER and medics have always used the Glasgow Coma Scale, GCS. That scores a 3 to 15. Obviously, the higher the number, the better. 15 is perfect. The GCS is a little complicated, and it's got a little controversy around it. You know, a lot of people have said it's a little subjective, and I guess it can be. But the GCS is a little cumbersome, so we're going to talk today about an easier, a more rapid assessment, and they call that AVPU, AVPU. It's a mnemonic again, right? Medicine loves its mnemonics. Let's first talk about why do we do mental status exams. So we know everybody gets a baseline exam, but in trauma patients, we do them initially, so the baseline, and then we follow up periodically, repeat those. They call those serial exams, and we do those because we're wondering, is there a head injury? Or is there some condition, either physiologically, like hypotensive, where there's just not enough blood and oxygen getting to the brain to feed those cells, or maybe metabolically. Maybe they're having a diabetic problem, they're not getting enough sugar. You know, they're hypoglycemic. They're not getting enough sugar to those brain cells. So either way, whatever the cause is, we do a baseline, and then we do serial assessments, follow-up assessments. And how often you do those follow-up assessments is going to depend upon how critical the patient is. Or not just that, but maybe it's the mechanism of injury or the nature of the illness. It's something that we think, boy, there's a potential risk. The risk here is higher, so we better follow up more often. I'll give you an example, right? Somebody that has a simple fracture, a long bone fracture, they fall off a skateboard, they break their radius ulna. Clean fracture, didn't hit their head, no loss of consciousness, just a simple fracture, right? Hurts a lot. We roll up on that patient, we're going to do a basic assessment. And part of that basic assessment is going to be level of responsiveness. So no head injury, no other medical conditions, just a simple fracture. You're probably going to do that assessment one time. And unless something changes, that's probably the only time you'll assess their level of responsiveness. Second patient, right? Somebody, same patient, but this time they fell off the skateboard, broke their arm, and hit their head hard on the concrete, right? So now your risk, the mechanism of injury, and the risk of something going on inside their skull here, you know, their brain swelling, maybe a bleed, a fractured skull, whatever the case may be, we're more concerned about a neurologic problem, a brain problem. So we're going to do the initial, and we might do serial assessments. Maybe we do them every 15 minutes until that patient's handed off to the next level of care. But so that's kind of what we do, how we, you know, and why we do it. Let's talk about how we do it. All right. So again, I've mentioned Glasgow Coma Scale. That's, you know, best eye, verbal, and motor responses. Most folks in medicine are familiar with Glasgow Coma. Again, a little cumbersome, takes a little bit of time. This AVPU is basically like a simplified Glasgow Coma Scale. It's a very brief assessment, AVPU, and the mnemonic stands for A is alert, V is verbal, P is painful or pain, and U is unresponsive. So all you're really doing, you roll up on a patient, how you doing? And if they can answer you, right? Appropriately, they can tell you who they are and what happened, and they're awake and alert and looking around. They're an A, they're an alert. That's perfect. That's the way most people are when you meet them, right? You slide down the scale, right? The further down we go, the worse it is prognostically, right? If you roll up and their eyes are closed, they're not responsive at all. They're only responsive to a loud shout. Hey, hey, are you all right? Wait, open your eyes and look at me. I need to talk to you. Yeah, verbal. If they only respond to verbal stimuli, then that's V, right? All right. A little further down the scale, you yell and yell and yell. They're not doing. They're still just out. Okay. Now it requires a painful, or sometimes you'll see P for physical, a touch, a shake. Most people use pain, and it's a sternal rub. A central pain stimulus, a sternal rub, can be a trapezius pinch, right? I like the nail bed pressure, right? But if you don't get a response from verbal, you try pain. You're not trying to hurt them. You're just trying to get a response. So it's, again, if and they don't have to wake up and talk to you, but if they open their eyes or they groan or they kind of pull away a little bit or they grimace, right? That's a response. So they would be responsive to P. So AVP. And then last but not least, U, unresponsive. So no matter what you do, they don't respond. All right. So that's obviously the worst scenario. Now, in any of these cases, in a first responder scenario, anything but A needs further attention. Right. So if they're alert, the way most people are when you talk to them, awake, alert. Now, here's the one thing. Alert doesn't necessarily mean oriented in the AVPU scale. And we're going to talk about that here in just a second. But if they're alert and oriented, everything's perfect. They're mentating clearly. Okay, you're probably okay as far as that goes. But anything short of that, they need to be further evaluated, right? Now, some mechanisms of injury, you're going to want to have them further evaluated anyway, even if they are perfectly alert and oriented. If they hit their head hard, you might want to have them scanned, make sure they're not having a bleed. They would be fine now, but in 15 minutes or an hour, they might not. So you always go by mechanism of injury. All right, so let's talk a little bit about alert and oriented, right? And this is just kind of an aside because this video is really about level of responsiveness. Oh, hard word. Level of responsiveness using the AVPU scale. But one of those little pet peeves of mine is alert and oriented, right? So I'm a critical care and ER nurse. That's what I've done for 30 years. I teach nursing, right? Everybody uses alert and oriented times 3, and really what we've gone to is alert and oriented times 4. So if you ask somebody are they alert and oriented, times 1 is to person, I know who I am, right? Alert and oriented to place, I know where I am, I'm at my home. Alert and oriented times 3 would be to time, so it's about, what, and they don't have to be exact, right? If you're in the hospital or you're just out bebopping around, you don't know necessarily that it's 11:05, but you know that it's almost lunchtime on the 31st. Today happens to be a Monday, right? If they can get that, they're alert and oriented at least person, place, and time. And then the alert and oriented times 4 is the event. What happened? And that's the one that a lot of people don't use. So a lot of hospitals use alert and oriented time, or nursing in particular uses I see a lot of nurses write alert and oriented times 3. Well, is alert and oriented times 3 out of 4, meaning there's a deficit, or is that alert and oriented times 3 out of 3? So you need to be clear. So the right way to write it, honestly, if you're gonna use alert and oriented times 3 or 4 in your charting, either write it out, alert and oriented is a person, place, time, and event, or write A and O times 4 over 4. So they're 4 out of 4. Anyway, pet peeve, I had to cover it because it kind of goes along with the level of responsiveness AVPU scale. It's kind of an aside, but hey, you get a little bonus. So again, I'm Rich Kutchman with Strategic Self-Reliance and Defense. Thanks for watching. I hope to see you in class.